And good morning. I'm Dr. Tim Williams, Chair of Medicine here at University of Louisville, and welcome to our annual Chairman Selection for Internal Medicine Grand Rounds. This morning, we are so pleased to welcome a colleague of mine, a collaborator, and a close friend. We've been together in society medicine and advocacy for so long now, and he has had an amazing career that has shaped how many of us practice preventive cardiology and lipid management is Dr. Alan S. Brown. He's actually an interventional cardiologist who has developed a penchant for preventive cardiology and lipidology. He's currently a professor of cardiovascular medicine at Wake Forest University School of Medicine, and was recently transitioning from being the longstanding director of the lipid clinic and cardiology at Advocate Lutheran General in the Chicago area. Dr. Brown earned his BS degree from University of Illinois in Champaign-Urbana and his MD at Loyola University. And he completed his internship and residency also at Loyola, served as chief resident at the Heinz VA, and then did his cardiovascular diseases fellowship at Loyola as well. He also was the chief fellow. He later pursued leadership training through Health Management Academy and GE Fellows Executive Program, and actually furthered that, completing a Master's of Healthcare Administration at University of Providence. He's board certified in internal medicine, cardiology, echo, and lipidology. Within the American College of Cardiology, which close to my heart and where I got to work with Dr. Brown even more, he's provided decades of service and leadership. He served as the Illinois chapter governor and president, and then as chair of the ACC's Board of Governor, which makes him the secretary of the college, as well as a member of the Board of Trustees. His committee work has spanned prevention, the annual scientific program committee, and the task force for appropriate use criteria. Beyond the ACC, he is also a past president and now master of the National Lipid Association, reflecting his international stature in lipidology and prevention. Dr. Brown's academic and educational footprint is equally impressive. He has authored numerous papers and book chapters on clinical lipidology, led and participated in multiple trials, major trials and outcome studies focused on LDL triglyceride, Lp(a), and he has been core faculty for the Salzburg-Weill-Cornell Seminar in Lipid Metabolism, helping train clinicians from around the world. Many will also recognize his voice from ReachMD's Lipid Insights and Heart Matters, where he interviews national thought leaders and translates evidence into practice. He also, as I mentioned, completed the Master's in Health Administration and Executive Training. We got to hear a little bit about how to organize a same-day clinic, which I think he used that for the thesis pretty much. A testament to his commitment to clinical excellence, systems improvement, and mentorship. Please welcome Dr. Alan S. Brown to deliver our annual Chairman Selection for Internal Medicine Grand Rounds. Alan, we're so happy to have you. Thank you for all of your accomplishments and your personal friendship.
Thank you, Kim. What a great introduction. I think my mother wrote that introduction, so I apologize for the lengthy it was. But I really appreciate that. So I'm going to try and give you a lot of information. Hopefully it'll be digestible about what's new in lipid therapies. And the reason I find this personally fascinating is that I was just starting in practice when lovastatin was approved, the first statin. And I remember thinking there won't be much more interesting in lipids now. We have this super powerful drug. But we were all very afraid of it because we thought that cholesterol was in every cell and that lowering cholesterol to really low levels might cause some kind of serious problem. And it became obvious over my first 5 or 6 years in practice that you can't be skinny enough, you can't be rich enough, and your LDL can't be low enough. And I said that about 35 years ago, and nobody's proven me wrong so far. So what I want to talk to you about today is newer therapies, where we're going, and then I'll finish with a study that was just presented 10 days ago at the American Heart that I think will affect guidelines, so you should be familiar with it. These are my disclosures. I do speaking and consulting, but so if that's a problem. Okay, so we have had a lot of therapies beyond statins now that when added onto statins have shown significant reduction in cardiovascular risk. Those include ezetimibe, which it showed benefit on top of statins, PCSK9 antibodies with outcome trials now, icosapent ethyl, the pure EPA omega-3 fatty acid, and even bempedoic acid with a study that was looking at patients who were totally intolerant to statins, and bempedoic acid showed clinical outcome benefits. There's a whole class of drugs called CETP inhibitors, which were sort of a failure. Two of them did not show benefit. One of them actually showed an increased risk of mortality and morbidity. But one of them, anacetrapib, probably by virtue of the fact that it not only raised HDL, but it lowered HDL. It showed actually modest benefit, but it stayed in the body for months and months and months. And that because the outcome benefit was relatively modest and because of concerns over safety with a drug that was stored in the fat for months, the company decided not to pursue approval for it. Now, what's been shown not to have outcome benefit is on top of a statin. So none of you, except for me, are old enough to remember there were studies in the 1970s with niacin compared to placebo that actually showed a reduction in cardiovascular events in those studies of men who had prior heart attacks and actually showed a mortality benefit. But when added to statin, 3 large studies showed no additional benefit, even though the lipids got better. Fenofibrate on top of statins, again, you could argue about the study design, but at least 2 large studies adding fenofibrate to patients who are already on statins did not show significant outcome benefit, even though their lipids got better, their triglycerides went down. And dalcetrapib and evacetrapib are the 2 CETP inhibitors that did not show significant benefit. So where are we today? Let me see if I could drive you crazy at the introduction. Didn't bore you now. So I'm gonna give you lipids 101. And I think people think that triglycerides and cholesterol are floating around in the bloodstream. They're not. They don't float around in the bloodstream because they're fat, and fat doesn't dissolve in water. So very cleverly, cholesterol and triglycerides are packaged into a little spaceship called a lipid particle. It has an outer surface coat of phospholipids, which are very unique in that they're water soluble on the outside and fat soluble on the inside. So the triglycerides and cholesterol are very happy in the core of the lipid particle, but because the outside is polar, it can go through the bloodstream. So we carry our cholesterol and triglycerides in those particles. And there's 2 ways we get those fats into the blood. One is by diet. Dr. Williams took me out to a dinner last night and I had a fantastic meal, which I'm sure caused me to incorporate a lot of fats into my bloodstream, even though he ate vegan food and I should have done the same. So when dietary fat goes into the intestine, it gets packaged into a particle that's loaded with triglycerides called chylomicrons. Chylomicrons has that outer surface coat and it has 10 triglycerides to every cholesterol, which is why if you don't fast for 12 hours and you draw someone's blood, what's abnormal is your triglyceride level, because you still have chylomicrons in the bloodstream and they're loaded with triglycerides. So what? Well, when that chylomicron goes through your capillaries, there's an enzyme in the wall of the capillaries called lipoprotein lipase that removes the triglycerides and breaks them down into fatty acids for energy. And what's left is a smaller atherogenic particle called chylomicron remnants. And those remnants are cleared by remnant receptors on the liver. So that's what happens with dietary fats. And think about it as triglycerides are the fuel that gets removed from lipid particles and used by muscles, for example. What's left over are remnants, which are smaller and more atherogenic, and those are cleared by the liver. And so there's relatively less triglyceride in a remnant, but still cholesterol. The cholesterol doesn't go anywhere. It stays in that particle until the liver picks it up. Now, what happens from your endogenous production of lipids? And that is that the liver makes a particle that's very similar to chylomicrons, VLDL. VLDL is also loaded with triglycerides. It has about 5 triglycerides to every cholesterol, so not quite as much as chylomicrons. But it travels through the circulation. Triglycerides are removed in the endothelium by lipoprotein lipase. And you get a VLDL remnant also known as intermediate density lipoprotein. And if you remove all the triglycerides, you get a particle that's basically all cholesterol, which is our old friend LDL. Very atherogenic, probably the prime driver of atherosclerosis. So chylomicron remnants, VLDL, intermediate density lipoprotein, and LDL are all atherogenic lipoproteins. Chylomicrons themselves are a little too large to get into the wall of the artery, and they're thought not to be atherogenic unless they're broken down into remnants. And then all of you know that LDL is picked up by LDL receptors, right? By binding the ApoB100 on the surface of LDL. But what you may not know, and is important, and we'll talk about this in a minute, is that remnant particles don't have to be fully metabolized to LDL. The VLDL remnants can actually go directly back to the liver via what we call the shunt pathway and bind to the same remnant receptors that chylomicron remnants bind to. And there they are metabolized by a lipase on the hepatocyte called hepatic lipase and broken down and taken into the liver, or the triglycerides can be removed and they can be released back into the bloodstream as LDL. So that's the one thing that you have to kind of memorize, is that shunt pathway. And we've tricked the body into using that pathway for certain diseases with new drug therapy. So we'll talk about that. So that's lipids 101. Lipids 102 is to try to understand a little more what's happening at the level of the LDL receptor, because most of our lipid lowering therapies actually work by increasing LDL receptors on the surface of the liver. So here's an LDL with a snake-like ApoB100 on the surface binding to an LDL receptor. It's taken into the liver and transferred to what's called an endosome. The endosome has a little bit of acid in it, just enough to separate the receptor from the LDL particle. And then the LDL receptor actually cycles back up to the surface of the liver, and it can do that 150 times a day and pick up more LDL. So what happens to the LDL particle? So once the receptor leaves the LDL in the endosome and goes back to the surface, the LDL gets transferred to a lysosome, which has lytic enzymes in it, lysosomal acid lipase, that breaks that particle down to cholesterol and the amino acids from the apoprotein on the surface. And the liver uses that cholesterol to make bile and to make VLDL particles. We now know that we also have a protein made in the liver called PCSK9. And when it's made, and we don't know why we have it or why it's made or what triggers the production, but when it's made, it gets secreted into circulation where it folds into its active form. And when it's present, it binds to either the lipid particle or the LDL receptor in such a way that it works like super glue. So now the LDL comes down and binds to the receptor in a normal way. The receptor and the LDL get taken into the liver, but instead of in the endosome releasing the receptor, both the LDL and the receptor go to the lysosome and get destroyed. So in the presence of PCSK9, you destroy your LDL receptors, meaning your liver can't take as much LDL out of the blood, and you get very high LDL levels. And this was discovered by patients who had inherited a gain of function mutation in the gene for PCSK9, and they looked like they had familial hypercholesterolemia, but they had no mutation in the LDL receptor gene or any of the other genes associated with FH. And they discovered this protein PCSK9, and it was being overproduced in those patients. And then they went and looked at patients who had extremely low LDLs, like 5, 7, 12. The oldest of them was in their 60s. And what's the most common side effect of having an LDL at 5 your whole life? Longevity, right? They didn't have anything, no cognitive issues, no cancers, but no atherosclerosis. And when they measured their genetics, they found that they had a knockout mutation in PCSK9, which stimulated some smart person to say, how can we just remove PCSK9? Because nature did the experiment, the people were fine without it, and not mess with any other proteins. How about an antibody? And that's actually what stimulated the development of PCSK9 antibodies. But now there are many, many different approaches to removing PCSK9. We're going to talk about that as far as new therapies. A few seconds on icosapent ethyl. This was a study that you're probably familiar with, came out of Brigham and Women's, the REDUCE-IT trial. We had 2 studies and several observational studies of giving traditional fish oil, EPA and DHA to people with very, very modest, if any, benefits. And one of the studies I was involved in, a strength trial where we gave high dose omega-3s that were similar to the commercially available fish oil at the time with EPA and DHA, and it didn't show any benefit compared to placebo. But there were a group of folks that said pure EPA alone is different. Icosapent ethyl is a different animal. And there was one open label study in Japan suggesting that it showed benefit, but it was criticized appropriately because it was open label and not blinded. So that led to this study, which was called the REDUCE-IT trial of icosapent ethyl alone compared to placebo. And you had to have significant atherosclerosis or high risk. And they were randomized to icosapent ethyl versus a placebo on top of traditional lipid lowering therapy. The results were stunning, actually. They had a number needed to treat of 21 to save 4-point MACE compared to placebo. And a lot of people didn't believe it, understandably, because there was only one product on the market that was driving the trial. And there was a lot of buzz that maybe because the placebo was mineral oil, that it increased the event rate in a placebo arm and made the drug look better than it really was. I happened to be president of the MNLA when this study came out, and I was very skeptical of it. We looked at it inside out, upside down. You can't explain the results based on mineral oil placebo, despite the fact that some prominent cardiologists have said that it's just highly unlikely. I think there is benefit with icosapent ethyl. And remember that these were in patients who had triglycerides over 150, who either had diabetes without evidence of coronary disease or had coronary disease. And it showed almost the same reduction in risk as adding a statin versus placebo, which was really quite striking. And the secondary endpoints of CV death, MI, and stroke had an absolute risk reduction of almost 4%. So for every 28 people you treated, you saved a major event. So this was a very positive trial. I was disappointed that our omega-3 trial didn't work, but I think we shouldn't forget that this was a well-done study from a well-done group that showed significant benefit with icosapent ethyl, and patients should be considered for that. What about bempedoic acid? So this was another way of trying to get at lipid reduction without the side effects of statin. So I don't know how much you know about bempedoic acid. It's a currently approved non-statin. It's given as a prodrug, so when you swallow it, it has no activity, but there's an enzyme required to activate it, and that enzyme is only in the liver, not in muscle, as opposed to HMG-CoA reductase, which is also in the muscle. So the concept was, we'll give this drug that blocks the same pathway that statins do, the cholesterol biosynthetic pathway, and it won't have any effect on the muscle, and we'll have an alternative to statins that doesn't have muscle side effects. Well, patients are goofy, so some of them will have a little bit of myopathy on anything, including sometimes taking an aspirin. But it appeared to be less likely to cause muscle side effects than statins. Not as potent as statins. It lowered LDL 17%, but when you added ezetimibe and they made a combination medication, you could get almost 40% LDL lowering. One of the Achilles heels was it can raise uric acid levels, so you certainly don't want to use this in anyone who's had gout or recurrent gout. But as I pointed out, it blocks the cholesterol biosynthetic pathway. HMG-CoA reductase is the rate-limiting enzyme that statins block, which is in both muscle and in liver cells. This blocks ATP citrate lyase, which is much higher up on the chain, and it requires this activating enzyme to work. And you would think that you get similar reduction that you do to statins, but not quite. It's not as potent as I mentioned, but the concept is fewer side effects. So they did something kind of crazy. They took patients who absolutely refused to take statins. They made them sign a paper that, you know, statins could actually save your life. They might reduce the risk of heart attack and death. You need to sign this paper that you understand that, but despite that, you're absolutely not going to take a statin. And they made their physicians sign the same paper, and they put them in a placebo-controlled trial, with a fair number of them having known atherosclerosis. And if you're designing a study, which I know you guys are familiar with research, you need enough event rate to show outcomes. And if you've got a drug that lowers LDL 17%, you're going to have a pretty high event rate in your placebo arm. So they found a way to take people with coronary disease who would refuse to take a statin for their placebo arm. And that enhanced the event rate, unfortunately. It's why I did not participate in this study, to the point where they were able to show a significant reduction in events in people who were statin intolerant. I will say they did allow people to drop in on PCSK9 inhibitors, but at the time the study was going on, it was hard to get those approved, and a lot of the patients did not get the PCSK9 inhibitors. So primary and secondary prevention patients, bempedoic acid versus placebo. These are the things they had to sign. I can't tolerate these medicines, even though I know they would reduce my risk of a heart attack, stroke, or death. And the doctor signed, in my opinion, the patient's unable to tolerate statin therapy, except maybe at extremely low doses. And they had a reduction in LDL that was predictable, anywhere from 17 to 20, 22%. CRP went down, which got people excited because they did see a drop in their HSCRP. And the trial was statistically significant with about 1.6% absolute risk reduction and a 13% relative risk reduction of 4-point MACE. So what did they learn from this? That something beside a statin, something that works differently than anything that had previously been on the market, actually can translate. It lowered LDL and it lowered cardiovascular events. Okay, so those are a couple of things that now we have on the market as options. And now comes the new era of oligonucleotide therapy. So this is classes of drugs that are going to be used in many different diseases, but they're perfect for the lipid scenario. And there are two types of oligonucleotide therapies: antisense oligonucleotides and small interfering RNA. Antisense, think of it as a mirror image of a messenger RNA you're trying to inhibit. So if you want to not allow PCSK9 to be produced, you make a single strand piece of RNA that's the mirror image of the RNA for the messenger RNA for PCSK9. You get it into the liver cell where it goes into the nucleus, finds the messenger RNA for PCSK9, and tricks the liver cell into saying, this is garbage. We no longer need that messenger RNA. So I'm going to turn on our RNA system to destroy that messenger RNA. We have our own garbage disposal system in liver cells and other cells. Once messenger RNA is no longer needed, an enzyme cleaves it and destroys it. So antisense, single-stranded, goes into the nucleus, tricks the cell into destroying the messenger RNA target, which, for example, could be PCSK9 or any other liver-made protein. Small interfering RNA is very similar. It's a double-stranded oligonucleotide. It already has a carrier and it has a trick messenger RNA that in the cytoplasm gets bound to a complex called a RISC, an RNA silencing compound. And when the RISC compound picks up that messenger RNA from it says time to destroy that messenger RNA. And that stays in the cell till the cell dies. So it has a long duration of action. And again, the mechanism is to turn on an RNase to destroy that target messenger RNA. It's just a slightly different approach. Now, one of the problems is if you want to get a drug like this into the liver, you had to give really high doses for it to concentrate into the liver. So actually a scientist at Ionis, who's a South Asian, very smart guy, he knew that the liver has receptors on it for galactose-like sugar. And it's called the acyl-glycoprotein receptor. And he got this idea, if we put that sugar on a messenger RNA, on our siRNAs and ASOs, the liver will take it up preferentially. Maybe we could get rid of some of the side effects of giving such high doses. And his boss told him, you're wasting your time. I got more important things for you to do. Don't do it. But he was so committed, he did it on the weekends on his own, against his boss's wishes. and he probably should get the Nobel Prize. Because now when you give these drugs with the GalNAc version, which is a galactose sugar conjugated with the RNA, whether it's an antisense or siRNA, the liver sucks it up like a sponge. You can give 1/10 the dose. That reduced a lot of the side effects, which included thrombocytopenia and other side effects when they had to give high doses. So now when you see GalNAc, you'll know what it is. All of these drugs now are GalNAc conjugated from any company, and that has allowed them to really reduce the dose and side effects dramatically, which makes them very useful drugs. So what's an example of one of these? Inclisiran, which is currently on the market. It's a small interfering RNA that targets PCSK9. And it's FDA approved, as you know. It has long duration of action given every 6 months, and it inhibits PCSK9. It reduces LDL about 52%. Does anybody know why PCSK9 antibodies that we're well familiar with, avolacimab and alirocumab, lower by 60 to 63%? Anybody know why? Inclisiran, which knocks out PCSK9 production in the liver, why it's only 52%?
Kidneys and intestine.
Other tissues make PCSK9 beside the liver. So if you give an antibody, you remove all of it from the circulation. Whereas with the siRNA, you're just stopping liver production. So it's slightly less potent than the antibodies. Okay, can we switch gears a little bit? Let's talk about some diseases where we didn't have good therapies, where some of these newer technologies actually have provided us opportunity. And one of them is homozygous familial hypercholesterolemia. So as you know, heterozygous familial hypercholesterolemia is very common. 1 in 250 people. If you haven't seen it, you don't know how to diagnose it because you've all seen one. They generally have LDL cholesterols around 200, but over 160. It's an autosomal dominant trait. So if mom or dad has it, there's a 50-50 chance one of the kids have it. There's 20 times the risk of cardiovascular event in those patients, to the general public. And the most common cause is a mutation in the gene for the LDL receptor. So they've inherited one bad allele for LDL receptor and one good one. They have only half as many functioning LDL receptors as normal. That leads to double the LDL in the blood. And the high LDL leads to atherosclerosis. Well, if 2 of those people get together, and it's possible when it's 1 in 250 in the population, there's a 1 in 4 chance that the child would get 2 bad alleles. And they would have no functioning LDL receptors or very poor functioning LDL receptors. Those kids can have LDLs over 1,000, and they usually have coronary disease by age 10. In the old days, we treated that with liver transplant, because liver transplant, you can put new liver with good LDL receptors in the patient. Sounds very aggressive, but it worked. And then LDL apheresis came along, where we can do like dialysis and remove LDL from the blood, but that's every 2 weeks, a couple hours sitting there getting apheresis. Statins, ezetimibe, every PCSK9 inhibitors have all been tried in these patients. And if their mutation doesn't totally knock out the function of their LDL receptors, they will get somewhat of a response. But starting at cholesterols over 1,000, not down to the goals we would hope, but they get some response. If they had knockout mutations where they had no LDL receptor function, statins, ezetimibe, PCSK9 inhibitors don't work at all in these patients. So they're stuck with apheresis. There were a couple of drugs that came on the market that reduced production of ApoB in the liver. And what they did, since you're now lipidologists, is they reduced VLDL production. If you don't make VLDL, you don't get to LDL, since they couldn't clear the LDL. But they were associated with fatty liver because you were not allowing the lipids to leave the liver. And though the patients do okay on them, they get a substantial reduction in LDL. There was a concern because over time, the fatty liver tends to increase. So we're always looking for new therapies for these patients other than liver transplant. And one came up with ANGPTL3. So you remember this diagram? And ANGPTL3 isn't shown on here, but it's a protein that inhibits lipoprotein lipase and another lipase called endothelial lipase. And somebody thought if we get rid of that, the lipoprotein lipase will be more effective. But I have no idea how they thought this might work for somebody who doesn't have LDL receptors. But it does. And what it does is that when you remove inhibition on endothelial lipase, it changes the surface components on VLDL remnants and makes them want to go back through this shunt pathway and not go to LDL. So you end up removing the lipid particles before they become LDL. So that's ideal in a person who doesn't have adequately functioning LDL receptors. And this is now currently on the market. It is evinacumab. It's a human antibody similar to the PCSK9 antibodies. Sorry. And it causes the remnant particles to go directly back to the liver before they become LDL. So for homozygous FH patients, it lowers their LDL up to 50%. Again, this was recently approved for homozygous familial hypercholesterolemia patients. Kind of exciting. I have no idea how they figured out it would work, but it does work. And interestingly, people who were born with a knockout mutation in this protein, ANGPTL3, which is what this antibody targets, they have lower LDL, lower triglycerides, and lower atherosclerosis risk. So beyond just a treatment for homozygous FH, which means they could charge a whole heck of a lot of money for the drug, because it's a drug for a very rare group of patients, there is potential in the future of reducing atherosclerosis. So another potential target to reduce atherosclerosis. And there are other companies doing different types, besides antibodies, doing siRNAs and antisense oligonucleotides against this target, ANGPTL3. So it reduces LDL triglyceride levels, reduces remnants, which are atherogenic, and knockout mutations look promising as a target for ASCVD. Okay. Another target, apolipoprotein C3. C3 is an inhibitor of lipoprotein lipase. If you develop metabolic syndrome or insulin resistance, you have a lot of C3 on your chylomicrons and your VLDL. And so those particles don't get broken down that well by the lipoprotein lipase. And that's why you see triglyceride levels go up in patients with insulin resistance. And we don't exactly know what triggers more of that apoprotein being deposited on lipid particles in patients with insulin resistance. Is it genetics? But we definitely see that. And similarly, knockout mutations in ApoC3 show a reduction in cardiovascular risk in populations where they have a knockout mutation. But what's very interesting is somebody tried this on people who have a rare disorder called familial chylomicronemia syndrome, and they don't have any functioning lipoprotein lipase. So now that you remember lipid metabolism, I'm going to explain this to you. Let's assume your lipoprotein lipase doesn't work. You make a chylomicron from your gut, 20 triglycerides to every cholesterol, and you can't break it down into remnants. The liver cannot take up intact chylomicrons. It only picks up chylomicron remnants. So you get chylomicrons in the circulation, your triglycerides are 2,000, 3,000, and they get recurrent episodes of pancreatitis. I have a patient who's had 30 episodes of pancreatitis since she was 3. And the only treatment, because you can't break down chylomicrons, is to put them on a really low-fat diet, like less than 10% calories from fat, which is very hard to tolerate. And even when they do that, some of them will have chronic abdominal pain, get pancreatitis. This is a very rare disorder because it's autosomal recessive. So it's about 1 in a million, somewhere between 1 in 300,000 and 1 in a million. But if you run a lipid clinic, you will see them. And so somebody got the idea, well, let's try and remove ApoC3, which will remove inhibition on lipoprotein lipase, and see if that works. But if you have a broken lipoprotein lipase and you remove inhibition, that shouldn't work. But it does, amazingly. So how does it work? Well, we're not 100% sure, but so ApoC3 does a couple of different things. It inhibits lipoprotein lipase, it inhibits hepatic lipase, but it also inhibits those remnant receptors that pick up remnant particles. And if you remove it, the liver can suddenly pick up intact chylomicrons, which in normal situations it can't do. The chylomicrons have to be broken down by lipase into a remnant in the normal situation, but without ApoC3, somehow the liver can pick up those chylomicrons. Now, another fascinating thing, just to bore you a little bit, is where do you think the liver gets the building blocks to make VLDL? That we know the liver can make cholesterol through the HMG-CoA reductase pathway, right? And it can make triglycerides. But it turns out that 75% of the cholesterol and triglycerides that the liver uses to make VLDL come from dietary chylomicrons. Chylomicron remnants are picked up by the liver, and they use that cholesterol and triglycerides to make VLDL. So if you're one of those FCS patients, chylomicronemia patients, you can't break chylomicrons down to remnants. The liver has no building blocks to make VLDL. And guess what? Your VLDL levels are very low, your LDL levels are very low, and you're unlikely to get atherosclerosis. You're just likely to get pancreatitis. So that's very interesting. That's one reason it's good to know these disorders, because you know what to worry about. If you're pre-diabetic, atherosclerosis is going to be high on your list. If you're chylomicronemia, you're much more worried about pancreatitis and a much lower risk of atherosclerosis. And one of the ways to help diagnose chylomicronemia syndrome is to measure an ApoB100 level, which is extremely low in FCS patients because they can't make ApoB100 particles, which would be VLDL, and their breakdown remnants. Okay, so two different drugs have been recently approved. Olezarsen is an antisense oligonucleotide that removes ApoC3, breaks down the messenger RNA for ApoC3. And plozasiran was just approved 2 days ago. It's a small interfering RNA, which also removes ApoC3. And for these really sick patients, it drops their triglycerides up to 80%. It's just a godsend for them. I always say there are very few diseases that keep lipidologists up at night. This is one of them. Because all your efforts, you put them on fenofibrate, omega-3s, they don't do anything. And the patient, you get that phone call, patient's in again with pancreatitis. Remember, pancreatitis is about a 6% mortality. I had a 10-year-old admitted 10 times in a year with pancreatitis. She could eat some chicken breast, but if she had a chicken leg, she got admitted the next day with pancreatitis. So you never forget these people when you're on a lipid clinic. You know their names, their family members, etc. Because it's a recessive trait, usually their family members have just mild hypertriglyceridemia and are carriers. But to have a couple of new agents that work for them is fantastic. And that's where the benefit of orphan drugs are. They're expensive because they're for a small population of patients, but they're the only option for many of these patients. All right, now for something probably you're more interested in, Lp(a). We've been talking about this for lots of years. One of the pioneers was in Chicago, a colleague of mine, Dr. Scano, was fighting for most of his life for people to recognize this as a cardiovascular risk factor. And what is Lp(a)? Lp(a) is a lipid particle that looks kind of like LDL. It is not LDL. It's packaged completely in the liver. But the lipid particle has a lot of cholesterol in it, similar to LDL. It has ApoB100 on the surface, which is what the protein the liver puts on particles. But it's highly oxidized. And oxidation of lipid particles makes them pro-inflammatory. So an oxidized lipid particle stimulates an inflammatory response if it gets into the wall of the artery. And attached to this lipid particle is a series of kringles, this protein, it's kringles, which is lipoprotein a, and it binds to the ApoB with the connection here. Now, so what? Well, there are a couple of double whammies you get here. Number one is because it's pro-inflammatory, it's very pro-atherogenic. It's a small and dense particle, penetrates the wall of the artery quite easily. Number two, there's an amino acid sequence on the apo(a), which looks similar to plasminogen. And remember, plasminogen is the body's natural anticoagulant. So this competes with plasminogen going to plasmin. So there's a risk of thrombosis, an increased risk of thrombosis. So you get two bad things. more clotting, more inflammation, and more atherogenicity. And now we measure these levels and have shown that levels of Lp(a). Oh, by the way, this is an autosomal dominant trait. It's inherited, and it's all coded by a gene LP(A) that determines your levels of Lp(a) levels in the blood. They stay fairly static most of your life. So most people believe we should get it. Everybody should get it at least once. And if you look at meta-analyses, Mendelian randomization, genome-wide association studies, higher levels of Lp(a) correlate with higher risk of cardiovascular events and mortality. So we've known about this for a long time. The problem is we don't know how we metabolize Lp(a) particles. We know how we make them. There's a genetic predisposition where your liver makes the Apo(a) and the lipid particle and secretes it into the circulation. But we have no idea how it's cleared. It's not cleared by LDL receptors. And in fact, when you give statins, the levels can go up. And so PCSK9 inhibitors can lower it a little, but probably not by increased clearance, probably by some mechanism of reducing production of Lp(a). But other than that, we've had no real way to lower it. So people have kind of ignored it. They knew about it. Lipid geeks have got excited about it. But the treatment has been to get LDL really low in those patients. And we have some data for that. I'm going to skip this for the sake of time. I thought I had a picture from the. Well, so in a couple of the large lipid lowering trials, they looked at people on statins versus not on statins, and they showed that even in those with high Lp(a), the risk went down on a statin. And that was encouraging, but it didn't go down as much as the risk dropped on a statin with people who don't have high Lp(a). So there was still evidence of residual risk. This was very important because some people have said, well, if statins raise Lp(a), you should measure it, and if your Lp(a) goes up, you should stop the statin. That is not the case. You know, regardless of the fact that the blood levels go up, the treatment is still get the LDL low with the statin to reduce the risk of Lp(a). But we've been struggling to try and figure out what can we do to lower Lp(a) levels and see what happens. And that has led us to the development of several new drugs, which you are now experts in. So we have 3 drugs in development: an antisense oligonucleotide that targets a messenger RNA for Lp(a), for Apo(a). So your liver it destroys the messenger RNA for Apo(a). You can't make Lp(a). Lp(a) is the lipid particle plus the Apo(a) on the surface. And the first one, pelacarsen, is in a trial called the Horizon trial, which will be published probably in February. And it lowers Lp(a) levels 80%. So we'll have to see, how much that reduces risk. It's high-risk patients with high Lp(a). The second one, which is called olpasiran, is an siRNA that targets Lp(a). It has the advantage of being given every 3 months instead of monthly, because siRNAs have a longer duration of action. And the third one, called lepodisiran, which Lilly has, is also an siRNA, but it's every 6-month drug. And both olpasiran and lepodisiran lower Lp(a) up to 100%. So they're all in clinical outcome trials. First one in February. I think the olpasiran OCEAN(a) trial will probably be a year or so later, and then lepodisiran about a year after that. A lot to get excited about if they work. But there's an old saying, the absence of data gives you the illusion of adequacy. Not everything that predicts risk is a good target of therapy. Years ago, 100 years ago, somebody described, I think William Osler described it, you have a horizontal earlobe crease that's associated with a higher risk of cardiovascular disease. But I'm just going to tell you, for the first time you've ever heard it, if you cut off the earlobe, it doesn't change your risk. And that's why we have to have prospective randomized trials. Not everything that predicts risk is a target. The nice thing about Lp(a) is there's a lot of biological plausibility that it should be a risk, it should be causal. And so there's encouraging science that probably targeting it will reduce risk. We'll have to see. And this is just the data showing a remarkable drop in Lp(a) levels with these 3 drugs. Now, the other good news is there's an oral drug for Lp(a), muvalaplin, which is very clever. And it is, what muvalaplin does is it binds to the apo(a) right at the spot where the apo(a) is supposed to attach to the apo(b) on the lipid particle. And it prevents the binding of apo(a) to the lipid particle, so you don't make Lp(a). And it has quite robust reductions in Lp(a), still early in development, a ways from a clinical outcome trial, but a lot of excitement about it. The other exciting thing is an oral PCSK9 inhibitor. This data was just presented to a couple weeks ago, looking at over 2,000 patients. And how does that work? The drug, which was very destroyable in the gut, they figured out a way to make it survive in the gut and go through the gut and into the circulation. And it binds to the PCSK9, where the PCSK9 would normally bind to the LDL receptor, and it blocks PCSK9 from binding to the receptor. And it drops LDL 60%, but it's oral. What do you guys think? Do we need an oral PCSK9 inhibitor? And how will that help compared to having injectables?
Depends on the price.
Well, a small molecule could be a lot cheaper, right, theoretically, than injectables. And the injectable prices have come down, but you know, it's kind of exciting. It's another alternative. But how are we doing with pills? Half the people who are on a statin after an acute coronary event are not on it in 1 year. 50% are off their statin in a year. That's shocking. After an acute MI or acute coronary syndrome. So I'm a little concerned that maybe this won't be the end all and be all. It could be cheaper, but the problem with pills is people don't always take them. So I love the idea of giving it a shot and being done with it. And that brings up some of the last few things. So we got these new promising agents for Lp(a). They appear to be safe, and we'll have to see the outcome data. Lastly, our old friend CETP inhibitors, which everybody gave up on. Guess what? There's another one. And it's a very interesting drug because it lowers LDL quite dramatically. And when you add ezetimibe to it, LDL can go down about 60%. Well, we got lots of drugs that lower LDL, but it also lowers Lp(a) pretty dramatically. It raises HDL dramatically, and we know that HDL is a lot like psychiatry. Half of what we know is correct, and nobody knows which half. The one thing we've proven over the last 5-7 years is that raising HDL doesn't seem to reduce cardiac events based on this type of drug, which is very potent at raising HDL. But the other fascinating thing about this drug is that it can remove amyloid in the brain, at least in animal models. And for people who have ApoE4, which is a significant risk for dementia, there's promise that CETP inhibitors may actually reduce the risk. And there's some small studies showing that. So we're a long way from a dementia trial, but this is the first drug that looks like it may potentially really reduce risk in patients with E4 dementia. So that's runs in families. I got a young man in his 50s who developed dementia. His kids who are professional football players all have E4. If this drug comes to the market for lipid lowering, and it's in outcome trials right now, what do you think I'm going to choose to treat them with if they need a dyslipidemia drug? Because it's probably going to take 10, 15, 20 years to see whether it really affects dementia, but certainly exciting in terms of the potential. So keep your eyes on this. Obicetrapib is in a large outcome trial right now. It raises HDL, which would probably has nothing to do with its benefit, but it definitely lowers LDL and Lp(a) pretty substantially. So there's a lot of buzz about it as a new class of drugs, and has that double effect of LDL and Lp(a). And with ezetimibe, you can get up to a 63% LDL lowering. So outcome trials for this are probably a year away. Finally, one and done. Gene editing drug. You give this drug, it goes in, it puts a missense base into the gene for PCSK9. So now when the messenger RNA starts to be made, it just falls away. It's permanent. So it's potentially a vaccine. You take the shot, it you will have PCSK9 inhibition the rest of your life. They only tried it in a dozen really sick people with inoperable severe coronary disease, but Lilly just purchased a company that makes this, so there's a lot of dollars behind it now. And you could think that in your lifetime, whether it be for an FH patient or somebody with coronary disease, we'll have to see what the indications would be. You could go in and get your shot, maybe everybody will get it and have 60% lower LDL for the rest of their life. Remember, lipid lowering is like a 401k plan. A little bit early in life translates into a huge return later. If you knock out the protein that ezetimibe treats, NPC 101, with a genetic mutation at birth, your LDL goes down 17%, but your lifetime risk of a cardiac event goes down 80%. So many of us are interested in the idea of primordial prevention, treat early, treating younger people with modest, safe LDL lowering, which could translate into huge reduction in risk later in life. Okay, the last thing for my last 5 minutes is, which I promised in the title, is, are there any trials that might change guidelines? Let's talk about PCSK9 and antibodies and what got into the guidelines in 2018. Do you remember they identified a group they called it very high risk? These were people that had more than one of the four major historical events: an MI, a stroke, peripheral arterial disease, or a recent acute coronary syndrome. If they had more than one of those, they were considered very high risk. Or if they had just one of those plus one of very hard to remember list of other side effects, other risk factors, like being over 65, having FH, having kidney disease, blah, blah, blah. So you might ask yourself, well, and they said those are people that are appropriate for PCSK9 inhibitors. Where did they come up with that? If a guideline doesn't fit in your shirt pocket, nobody's going to remember it. And they came up with it because they're purists, and then nothing against the guideline writers. I have a lot of respect for them. But they are committed to only saying what they absolutely know is true. So they looked at Odyssey outcomes and Fourier, the outcome trials with PCSK9 inhibitors, and they cut and pasted the enrollment criteria and said, these are the people where there's been a study that proved that these drugs work. So these are the people that should be the people appropriate for getting those drugs. Now, in practice, we all tend to give those drugs to people with atherosclerosis whose LDL is not adequately controlled. I doubt very many of you go through those four majors and look at the minors and try and see do they fit the so-called very high risk. But that's what the guidelines say. So one of the companies that makes a PCSK9 inhibitor said, you know what? We're going to look at these drugs in people who haven't had an MI, haven't had a stroke, but who have evidence of atherosclerosis, kind of what we do in practice. We're going to treat those people. And they had to have an LDL greater than 90. And this was called the Vesalius trial, just presented 10 days ago at AHA by Dr. Bahula. So I stole her slides. So the concept was that LDL is a well-established risk factor. Lowering it with PCSK9 inhibitors showed a decreased risk of events in people with a prior major event, like an MI and stroke, but it hadn't been shown in people who had not had an MI and stroke. So what Vesalius looked at was people with diabetes plus some risk in cancer, which would be like nephropathy or retinopathy. They had to have the diabetes at least 10 years and be on insulin. So they were likely to have coronary disease. Or people who had evidence of coronary disease, either by prior angioplasty or a cath, or a calcium score over 100. Which most of us would think we should treat those people aggressively, but there hadn't really been a trial. A PCSK9 antibody that you're familiar with. And of course, Fourier looked at people with a prior MI, stroke, or peripheral arterial disease. That's where the guideline group said those are the people who should get a PCSK9 inhibitor. So we have potential, if this works, change the guidelines that it's okay to use PCSK9 inhibitors in people who have not had a major event. And so these were stable patients. They were randomized to usual care. They had to have an LDL over 90, despite being on statins or ApoB over 80, and optimized statin therapy, and they could be on ezetimibe. And then they were randomized to evolocumab, 140 every 2 weeks, or placebo. And they looked at 3-point and 4-point MACE. And this study went out to almost 5 years, so longer than Fourier and Odyssey outcomes, which ended at 2.6 years. It was an international study. Baseline characteristics, I'll just point out that these are people who had no qualifying atherosclerosis. That would be the high-risk diabetics where they didn't really know if they had any AS, CVD, peripheral arterial disease, etc., but no stroke, no MI. Types of patients we see all the time who have evidence of atherosclerosis on their carotid Doppler, for example, but did not have. And they were pretty well treated in terms of 68% were on high intensity statins. Now, it's kind of shocking that their average LDL was 122 in the baseline. So despite the fact that a lot of them were on drugs, they weren't getting their LDL as low as we would all like it. And that's just the world that we live in today, unfortunately. And here's what happened, as you might guess, Avalokimab people. So by the end of the study, the average LDL in the placebo arm dropped to about 109. So they were in a trial. People were looking at them. They're trying to get their LDL a little bit better. They got to 109. But the LDL dropped to about 45 in the Avalokimab group. And of course, you'll see that they did okay with a 45 LDL. In Fourier, the average LDL was 26. And nobody grew a new liver or a third arm or anything. They did fine. And this is they had 25% reduction in CHD death, MI, or ischemic stroke. The number needed to treat was about 55. Over 5 years of these people who haven't had a major event, but who had evidence of atherosclerosis. And this was a dual primary endpoint, a 4-point MACE, which included revascularization, 19% risk reduction. Number needed to treat was a little bit better than that in the high 30s. And all these secondary endpoints got benefit, except when they get down to cardiovascular death, though, there was a trend. It wasn't statistically significant. So when you do a hierarchy of primary and secondary endpoints, the minute you hit one that's not statistically significant, everything else is exploratory, then you can't say much. But the trend was in the right direction. There certainly was no signal of increased mortality from being on these drugs, and a signal suggesting decreased mortality. So all-cause death actually went down by 20%. Exploratory, but interesting and certainly reassuring. And it fits right along the cholesterol trialist curve for when you lower LDL by a certain amount, how much risk reduction you get. So nothing earth-shattering. You lower LDL in these patients, they get a reduction in event. But I'm quite sure that's going to change the guidelines on who gets PCSK9 inhibitors, and that's well overdue. So we've seen guidelines reduce the numbers. These are now people without coronary events, without a very high risk, but evidence of atherosclerosis, and getting them down close to 40 on their LDL showed significant reduction in risk, adding a PCSK9 inhibitor on top of statins. It's in the New England Journal, which was published the same day it was presented. So in conclusion, and I got too many things on this slide, there are new therapeutic targets that offer fresh opportunities, particularly for some rare diseases where there were no other treatments in the past, except, very, very painful diets and lifestyle changes, which still have to be there, but now we can really reduce the morbidity for these patients. We got monoclonal antibodies, antisense therapy, small interfering RNA drugs that appear to be effective and well tolerated. And now with GalNAc, we can reduce the side effects by giving lower doses. They are perfect for targeting almost any protein you can imagine. We've learned how to use them and get them into the liver, and whether we'll have to target other organs in the future, it will be different challenges. We got therapies for ANGPTL3. We have therapies for Lp(a), ApoC3, all lipid active targets that have promise and may turn out to actually reduce atherosclerosis in the past. CETP inhibition, which we thought was dead, actually might be back with a drug that lowers LDL and Lp(a). We'll see soon what the outcomes are, but the possibilities for ApoE4 dementia, which has been a curse. If you have a single allele with E4 and your others is normal at E3, you have 3 times the risk of dementia and 10 times the risk if you're homozygous. So people are just panicking now, and everybody who has a memory issue gets those genetics drawn. And the idea that we might have a potential treatment to prevent progression of dementia in those patients is very exciting. Gene editing, the idea of one and done, one shot, and your LDL's low for the rest of your life is very interesting, but you can't reverse it. So we have to be careful how we fool Mother Nature. And as the old saying goes, never be the first or the last to try something new. And aggressive LDL lowering now in patients with subclinical atherosclerosis using PCSK9 antibodies has been shown to be safe, effective, and reduce cardiovascular events. So after 30 years of doing this, and after thinking that lovastatin just came out, we really don't want to be much more exciting in lipids. I have to say that as much as I love intervention, every month there's something interesting in lipidology, and I hope I haven't bored you too much with the presentation. Thank you.
Really spectacular and eye-opening, a lot to digest, as you mentioned. I do have a couple of questions. I'm sure everyone, and I bet we have them online as well. The concerns from it was Canhart and Copenhagen showing increasing HDL, that now U-shaped curve that we just didn't know anything about, and higher HDLs leading to more mortality and more cardiac events. All right, didn't that take a little bit of the excitement away from doing C-type inhibition again? And
I don't know that, when the C-types got decided they weren't going to pursue them, it was more the outcome data. This U-shaped curve thing has become a little more prominent in the literature recently, and it's observational data, right? So if you look at observational data, you see that very low LDLs are associated with intracranial hemorrhage. Anyone heard that?
Yeah.
So if you look at a broad population, whether in China or the United States, you look at millions and millions of people, really low LDLs, you see a little higher incidence of intracranial hemorrhage. But in clinical trials where we've lowered LDL to 26 and 14,000 patients and followed them now 7 or 8 years, we don't see any signal of intracranial hemorrhage. So is there some reason that some people with very low LDLs have morbidity? It could be that they got cancer, they got malnutrition, they got something else. It's an association, it's observational, but it isn't necessarily that the low LDL caused the intracranial hemorrhage. We see the same thing with HDL. If we look at a broad population, there is this U-shaped curve where people, in that 60 range have the lowest mortality. And it's not all cardiovascular mortality. But as you get up over 100 for men and over 110 for women, you start to see that curve observationally look like there's more mortality. Could be there are a lot more alcoholics with high HDLs. Yeah. So again, it's hypothesis generating. One theory, however, is that the receptor protein that picks up HDL on the liver, and it might be mutated in certain individuals. So they don't incorporate cholesterol from HDL into their liver because their SRB1 receptors are mutated. So they have higher levels of HDL in the blood, but they don't have the reverse cholesterol transport because they're not able to offload that cholesterol back to the liver. Remember, HDL goes out, picks up cholesterol from the peripheral tissues and delivers it to the liver and also to the steroidogenic organs, ovaries, testes, and adrenal glands. Which is why when your patients go to functional medicine doctors and they come back and tell you my testosterone's low and the doctor told me it's because you put me on this cholesterol lowering drug and my LDL is only 20, you can say BS. Because LDL has no role in delivering cholesterol to tissues that make steroid hormones. It's all done by HDL, which is not affected by the drugs that we give. But with that said, that's a digression. So this is an observation, but what to do with it is unknown. And we only saw the excess mortality with the one CETP inhibitor, which was thought due to the off-target effect of raising blood pressure, not because of the high HDL. So more to come on that. It's observation, but not necessarily cause. That makes sense.
It does. So the other real question is that, not enough of us are measuring Lp(a). And most of us were thinking that, once a patient has coronary disease, we don't really need it. We already know that it's a risk factor for developing. If you already developed it, why would you need that? But based on what you're saying, I'm thinking that maybe it changes our target.
Yeah, I think if it's an enhancing factor, so in 2025, if you have an elevated Lp(a) with a patient, number one, you want to screen their family because it's a dominant trait.
Yep.
And you want to note it. But that individual with established atherosclerosis, you're going to get their LDL really low, maybe lower, maybe instead of being happy with 65, you're going to want to get them down to 45 because we have, you know, at least some observational evidence that getting that LDL lower is going to reduce their risk. And then you're going to want to keep your ears open. So what if Horizon comes out in February and shows remarkable benefit lowering Lp(a)? And you know that 20% of your patients have elevated Lp(a), but you never measured it. You know, you're going to be playing catch up. It's a $30 test that's covered by most insurance, and there's a code in Epic for elevated Lp(a). Sorry. Somebody forgot to take the garbage out. So why not measure it? Again, it's pretty stable. So you could get one reading and they either have high or they don't. But then put the diagnosis in Epic so you're prepared for the future. If it turns out that those patients would benefit from a therapy that lowers it, it's easy to retrieve them. So I've been getting it. I think the MNLA most recent statement suggests everybody get at least one level in their lifetime. Now, it may turn out, because these studies have been extended, that's a bit of a signal, right? So both Horizon and the Lilly Acclaim study, they extended it. That suggests to me maybe the event rates weren't as high as they anticipated. And it's possible that because in Horizon, that baseline LDLs are 60. So these are well-treated patients. Maybe they have attenuated some of the predicted risk for Lp(a). And so we may not see as big a benefit as we thought. It may turn out that different sizes of the particle are more atherogenic. I'm sure all of you have had a patient come in horrified. I got my Lp(a) level, it's really high, and they have a 0 calcium score. No sign of anything. Similar to LDL. Not everybody with high LDL has disease. And the way I explained it, I bored them with this last night, is not everybody who crosses the street with the red light gets hit by a car. Some people make it. So not everyone with high Lp(a) is going to have disease, and we're going to need to learn who do we have to worry about. Do we have to look at more maybe subfractions of Lp(a), because those kringle sizes are quite different in different individuals. The smaller the particles, the more numerous and the more atherosclerotic. But we don't have an easy way to measure that right now. I will tell you that nanomoles per liter gives you a better idea of how many particles than milligrams per deciliter. And so you want to definitely look at how it was measured and make sure your lab is doing it in nanomoles, but study might be a bust. So in the meantime, get the LDL lower, keep your eyes open, and it's probably a good idea to measure Lp(a), certainly on your people with atherosclerosis or a strong family history. And then the science will evolve whether everybody needs one.
Fantastic. Other questions?
So first of all, I have to say, I think I remember now why I got interested in lipidology. So Alan Brown was my first mentor, and if you listen to him today, he makes difficult concepts seem so easy to understand, and that's his style. Just a great teacher. So I have one question and then two comments. So one, I agree with you about Lp(a). We check it in our clinic routinely, in my clinic. The MNLA and the ESC recommend once in a lifetime. I won't speak as to what the guidelines, which will be released in 3 months, will say, US guidelines, but maybe they will. I'm going to wager on that. The HDL point that Dr. Williams raised is really important. I think it's reassuring that Brooklyn and there's another trial with obicetrapib, Brooklyn and Broadway.
Yeah.
And the interim analysis showed reduction in MACE, not pre-specified interim analysis. So we'll see what prevails goes with long-term occupancy data, but I'm hopeful it'll reduce events.
I'm hopeful too.
Yeah. So the question for you really is, with to me, the nucleic acid therapies, like you said, nobody takes their pills. These seem very promising, even if it's once a year, because the risk once it gets activated, it just keeps on destroying the mRNA. You give, once every 6 months, once a year. I'm looking in the future, next 10 years, which you've done this for 30 years. As I look in the future, I think of agents that'll knock down ANGPTL3 and FGF21, like we were talking about last night, and so many other of these mRNAs that are bad for cardio, kidney, metabolic health. And so you just get on, one or two injections a year, and it takes care of all your bad metabolic stuff.
Yeah,
And
and
I think
so
that's what we'll see.
I do, and I think it's because of the way medicine is going too. So you guys probably your eyes glaze over when your CEO talks about movement to value, and maybe as a university you're a little insulated from what other large healthcare systems are going through. But what they're anticipating is we're going to move to a situation where the insurance company tells us we're going to give you $100 a month for everybody you take care of, times all the patients in your panel, and the rest is your problem. So you're going to have to worry about what your costs are, and yet you're going to have to hit quality metrics to make sure the outcomes for the patients are good. But this is all you get. And Medicare is already moving in that direction with their so-called MIPS program. So now you say to yourself, okay, I can't leave it willy-nilly to let my patients who have coronary disease have an LDL of 120, because I'm going to go bankrupt and my quality metrics are going to be terrible. This is not such a bad thing. This may turn into a good thing for patients. For the payer, it's fantastic. I know exactly what my bill is next year. $100 times all the patients this healthcare system's taking care of. That's my bill. And I can plan for it. For the healthcare system, it's a real problem. Somebody gets a complication, they have to have their gallbladder out after their bypass surgery, they're in the hospital for another week. You've got to absorb those costs. It's just a reality of life in a capitated, value-based system. So what are you going to do? You're going to say, I'm not going to leave it up to the patient whether they take their statin or not. I'm going to bring them in for a clinic visit every 6 months, and I'm going to give them a shot, and then I can forget about it. I know their LDL is down by 52%. Or if I had a one shot for life, I'm going to give that to at least all my high-risk patients. And now I've taken care of it. And probably there will be a burden on the patients. So how do you manage a group like that? You'd have to say, I'll tell you what then, if we're going to be capitated, those patients can't go anywhere but our healthcare system. So if they're in our insurance, they have to stay at University of Louisville. They have to get their x-rays here, their echoes here, everything else. Because if they go out to Dr. Schmo's office and he decides to do an echo every 3 months, that costs me money. But if I have him in my system, I know he just had an echo. I'm not doing another echo on him. I know he just had a chest x-ray. He doesn't need X, Y, or Z. In other words, you have to integrate the patients into the system, and you have to somehow make them have some responsibility for taking their medications and keeping their appointments if you're responsible for cost of their care. So that's where the world is going. So these newer drugs like siRNAs, gene editing therapies, they fit into what our CEOs are laying awake thinking about. How are we going to manage our population, make sure they get care that's proven to work, rather than kind of leave it up to the whims, or if their neighbor tells them your liver's going to fall out if you take a statin, they stop it. And when do you find out? A year later when they come back for their annual appointment. And the other piece of the future is going to be wearables. So you're going to know the day your PSA goes up in the future. You're not going to wait for your annual appointment. You're going to know that the blood pressure is not controlled or somebody's got sleep apnea in real time. And again, when you're responsible for good quality care and keeping the costs down, someone's going to have a dashboard and call you up and say, you must have gained some weight, you're snoring, we have an apneic spells, get in here right away. It's exciting, actually. But imagine your patients are never discharged. And instead of having to come in through a big, expensive facility where you have to be able to diagnose everything and treat everything, most of their treatment is going to be done at home. And probably we're going to have a lot of smaller facilities that are expert at doing common things, like a hernia hospital. Everyone who gets a hernia goes to that hospital. They don't need an MRI scanner. They don't need to be able to diagnose Maffucci syndrome. All they need to do is be able to do the hernias well, an outpatient angioplasty center, etc. I mean, that's the way the future looks. They could be perfect at it with very low complication rate because that's all they do. And you don't have to bear the cost of being able to both treat everything, diagnose everything, operate on everything that big medical centers currently do. Those will be fewer and far between. and the common stuff will be common and much less expensive and more efficient. So there are a couple of books on this if you're bored. One's called The Innovator's Prescription for Changes in Healthcare. That's really fascinating if you got nothing better to do. But I really think that's where we're going, and we're being pushed that way by the way we're going to get compensated. And for you younger folks, be part of it. You're going to be asked someday, would you like to be on a quality committee? Would you like to help us with managed care or with value-based stuff? And the answer should always be yes. Because I know many people who are internists on a quality committee who are now CEOs of very large healthcare organizations. And the only difference between them and everybody else is they said yes when asked to do something that made them a little high.
So I know we've gone long. We went from lipidology 101 to health systems of the future 101. But I know we do have a couple questions online, and maybe we should add that. No,
that should answer more quick.
No, those are everyone's fascinating. I'm watching.
Yeah, actually, real quick, we had one from Dr. Hannon, Dr. Scott Hannon from our infectious diseases group. He said, you mentioned the role of dietary fat intake in hyperlipidemia, but what percent of hyperlipidemia stems de novo lipogenesis from high concentration liquid carbohydrate intake rather than dietary fat intake?
You know, that's a great question. So in people who develop obesity, insulin resistance, diabetes, carbs are a big factor because of calories. But people with higher LDL, high saturated fat is a big factor. So you can go to any population on Earth and look at the saturated fat content in the diet and predict mortality. You don't have to measure any lipid levels. So we know that eating a diet high in saturated fat is associated with atherosclerosis. But the current easily available calories with high carbohydrate diets is leading to the obesity epidemic, which then starts that whole cascade of insulin resistance. So you have to do a combination of things, which is minimize calories, but ideally do what Dr. Williams does. A plant-based diet is the least inflammatory. And there have been some really interesting studies that look at all the inflammatory markers that are associated with atherosclerosis. And of all the diets, a pure plant-based diet is the least inflammatory. So somewhere in between, I was teasing these guys last night that the problem with willpower is it has a half-life of 2 weeks and it's soluble in alcohol. So one thing we're not good at prescribing is behavior change. We're really good at prescribing meds, but we need a behavioral change to really improve the health of the population. And that is something we need more study on. It's difficult. And the body fights you. So going on a diet, your brain tries to make food smell better, make you more hungry. You get less satisfied as you try and lose weight. So you're constantly being fought, which means that once you developed obesity, insulin resistance, you need to be on lifelong weight reduction therapy. The idea that you're going to take a GLP-1 agonist and lose weight and then you'll be good for another 10 years just doesn't work. Your brain has changed as you get obese and you need therapy forever. And there'll be periods where you plateau or where you start to get cravings where different drugs have to be added. And so we're not great at those things yet either. But there's a lot that needs to be done from a population standpoint to improve the health. And it's not just the components of the diet, it's just the readily available calories on top of it.
Excellent. A couple more just real quick. Says, what's the latest on the HDL/triglyceride ratio versus LDL for predicting CV outcomes?
Well, I'm not a big ratio fan. I think what a lipidologist does is you look at the lipid profile and you try to ask yourself, what particles are the problem? Is it LDL, VLDL, chylomicrons that are leading to this? And you can get some clues just based on the triglyceride to cholesterol ratio. And then the next question is a new question, which thank God we have an answer to. How much do I have to worry about this patient who's got elevated LDL or elevated triglycerides? And the question then is, do they or don't they have atherosclerosis? In the past, we treated everybody. We're worried about you. But now we have calcium scoring. So we can actually look at their heart, and instead of putting them into a calculator and comparing that individual to 1,000 others like that, we can simply take a picture of their heart and see do they or don't they have atherosclerosis. I already told you a third of people, I told you not everyone who crosses the street with the red light gets hit by a car. A third of people with cardiovascular risk factors, dyslipidemia, hypertension, have nothing on their calcium score. They have a 0. And the vast majority of those, 98%, have an excellent 10-year prognosis. That doesn't mean you don't treat them, but it means you have the option to say to them, okay, if you absolutely don't want to go on treatment, you got a good 10-year outlook, we're going to repeat the calcium score in 3 to 5 years. And it's not unreasonable to leave you off treatment, even though I don't like your LDL. But the other option is, how about trying to keep you at 0? You know, your LDL's high, and we could try something, and if you don't have side effects, then it gets your LDL lower, it'll change your 20, 30, 40-year outlook. But you can give the patient both of those options and be comfortable if they're at 0. But if they have atherosclerosis, it doesn't matter what their ratio is. You got to treat their atherogenic lipoproteins aggressively, as well as all their other risk factors. So I think all those ratios, all the biomarkers, HSCRP and everything I traditionally did, the best biomarker is the calcium score, in my humble opinion.
One last one is from Dr. Krishnasamy in our endocrinologist. He now says lipo-A fasting or non-fasting.
Yeah, it doesn't really matter. It's fairly stable, so you could kind of draw that anytime. There's maybe a little bit of fluctuation with diet, or for example, women going on estrogen therapy, etc. But in general, you can just draw it. And in fact, as I mentioned to you, if someone doesn't fast, the biggest concern is their triglycerides might go up a little bit if they're not fasting. LDL doesn't change that much. So if you're trying to assess someone's therapy, did you take your pills, or I've never seen you before, what's your LDL level? You don't absolutely have to do a fasting lipid profile. And in fact, in our same day clinic that you brought up, we did lipid profiles right then. The biggest predictor of fasting high triglycerides is, of non-fasting high triglycerides is fasting high triglycerides. So if you see the triglycerides way up in a non-fasting patient, they probably have a problem fasting also. But in general, the most important reason to do a fasting lipid profile, or the LP is not an issue, but is to try and make a genetic diagnosis. But otherwise, it's not that critical.
That's all for him.
Well, fantastic. We turned grand rounds into a real symposium. I really appreciate
Yeah, thank you. Thanks.